Welcome to our webinar tonight on CKM syndrome, which will explain to you what all that means, and hopefully, we'll all have a much better understanding of the relationship between cardiovascular, clinic, and metabolic syndrome. Special thanks to our registrants, some 2,000 of you, including a number of international registrants. As is normal in Australia, we begin by acknowledging country, the traditional owners and custodians of country throughout Australia in their continuing connection to waters, community. We pay our respect to them and their cultures and elders past, present and future. And I would extend that to traditional owners around the world. We have the most wonderful set of panelists for you today, international experts in their own right in these fields, but also people that have got very much their feet on the ground in terms of managing difficult patients with this particular set of conditions. We have Dr. Chiadi Ndumele from Hopkins, and he is very well known in this field, but also has been responsible for writing what has been the most recent sort of Bible on this particular subject. That's he was chair of the guidelines committee for the American Heart Association guidelines on CKM. We've got Professor Elif Elkinci from the Austin Hospital, and who leads the National Centre on Accelerating Diabetes Innovations, and Karen Dwyer, who is Director and Professor of Nephrology at the Royal Melbourne Hospital and University of Melbourne. And our general practice representative today is again someone very well known to many of you. That's Professor Garry Jennings from Tasmania, who's a general practitioner and an academic GP there. And I'm Garry Jennings, and I'm chairing this meeting. You can submit your questions at any time through the Q&A box, and it's now my great pleasure to introduce, as I said, one of the real authorities in this particular field, Dr. Chiadi Ndumele. Thank you very much, Chiadi.
Thank you so much. It's really quite a pleasure to be here with you all today to be discussing cardiovascular kidney-metabolic syndrome. So my talk will hopefully try to shed some insight into the nature of this and how we think about addressing this. I'll divide this into three parts. It'll be, why is this something of great importance? Then what does CKM syndrome mean? And then finally, what are the approaches that are appropriate for addressing CKM syndrome? I have no disclosures and won't be describing any referencing unlabeled or unapproved drugs or devices. In this past fall, as was mentioned, there was a presidential advisory and a scientific statement on cardiovascular kidney-metabolic syndrome released by the American Heart Association. So why is there such a focus on cardiovascular kidney-metabolic health? Well, there's multiple reasons for this emphasis. So first of all, we now recognize that there's a very close interconnections among metabolic risk factors like obesity, diabetes, and metabolic syndrome, chronic kidney disease, and the cardiovascular system. And we've known now that there's a shifting phenotype of population risk for cardiovascular disease, where we're seeing an increasing burden of obesity, diabetes, and chronic kidney disease, as well as having earlier presentations with cardiovascular disease. There's multiple consequences of CKM syndrome, but the principal one is premature mortality, which is primarily of cardiovascular etiology. And additionally, CKM syndrome is probably the major driver of disparities in cardiovascular rates and outcomes. But given this public health urgency, it's also important to note that we have key opportunities with better scientific understanding and then multiple new therapies that impact metabolic, kidney, and cardiovascular disease outcomes. This is what we call a hierarchical clustering analysis that really tells you about what the major phenotypes of risk are and how they've changed over the last few decades. So looking back at 1990, if you start at the beginning, you can see that we had a good amount of purple and blue. Those are basically hypertension and hypercholesterolemia. If you go over time, you see that the proportion of individuals for whom that's their major phenotype has decreased steadily over time. In contrast, you see an increase in the orange, which is severe obesity, and an increase in the light blue, which is chronic kidney disease, and a stable amount of severe hyperglycemia. So in general, we're seeing less hypertension and hypercholesterolemia as the predominant phenotype, and more obesity, CKD, and hyperglycemia. And this is not happenstance. We know that these are all pathophysiologically quite interconnected. And we know that most of the time, excess and or dysfunctional adipose tissue, particularly when built up in the ectopic fat depots like the liver, leads to inflammation, oxidative stress, insulin resistance, and vascular dysfunction. These pathophysiologic processes increase the likelihood of developing metabolic risk factors, the likelihood of chronic kidney disease, and also directly lead to cardiovascular disease, as do these metabolic risk factors in chronic kidney disease. Additionally, we know we have heart-kidney interactions known as cardiorenal syndrome, and the likelihood of these are further potentiated by these central pathophysiologic processes. So all of these are quite interconnected to cause multi-system dysfunction. As I mentioned, the premature mortality is the principal clinical consequence of CKM syndrome, and each of the individual components we see this. So severe obesity, we see a survival reduction of 8 to 10 years. Diabetes, survival reduction of 13 to 14 years, with greater survival reduction if a diabetes onset is earlier, and CKD stage 4 versus EGFR greater than 60, a greater 20 years the survival reduction. However, we know that these things don't usually occur just in isolation, but rather in tandem or in confluence. So we often will see confluent CKM risk factors, and that results in a synergistic increase in risk for mortality. So for example, 10-year mortality rates for diabetes are around 8% in a nationwide sample. CKD rates about 11.5%, but when you put them together, we see diabetes and CKD associated with over 30% 10-year mortality, the sum being more than the parts, this synergistic increase in risk. Now, a very major challenge related to CKM syndrome is health disparities, where we see a greater burden of CKM factors in those with more adverse social determinants of health: diabetes, metabolic syndrome, chronic kidney disease, and also impaired quality of care, all quite related to this. And we know that these social determinants of health at multiple levels impact CKM syndrome. They drive the development of CKM factors, as well as directly impact health behaviors. They actually change whether you get these CKM factors detected early, and also the risk of disease complications in CVD and mortality from CKM factors. And while we have a growing array of therapeutic options, we know that these are more restricted in those with more adverse social determinants of health. And this challenge that we have of navigating the health system with multiple providers and therapeutic plans is also more challenging in those with more adverse social determinants of health. And I just want to emphasize that we have factors at multiple levels, at the societal level, community level, and interpersonal level, that all work together to impact behaviors. And while we may have different biological predispositions, these should all be considered within the context of this social framework. So we have to think about social determinants of health in all aspects of our care for CKM syndrome. Additionally, a major additional challenge is fragmented patient care. We know that people who have multi-system dysfunction are often seeing multiple providers: cardiologists, nephrologists, endocrinologists, and of course, the primary care physician, who's at the center of all this. And it could be quite challenging to have appropriate communication, appropriate collaboration among these providers. It's hard for sometimes patients when they may be hearing different messages from different providers, and then also things can fall through the cracks. So we need to move from this fragmented care model to a more harmonized care model that involves more a patient-centered approach, thinking about not what our individual system is seeing, but what the patient is seeing in terms of the multiple risk factors, as well as a greater focus on coordinated care and addressing the social context. To address these issues, the American Heart Association brought together a team of multidisciplinary scientists and clinicians, led by myself, Cheryl Chow, and Janani Rangaswamy. And really the idea was to use this multidisciplinary group to address this multi-system challenge. So what is CKM syndrome? Well, simply, CKM syndrome can be described as a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity that leads to poor health outcomes. It's important to emphasize that CKM syndrome includes both individuals who are at risk for cardiovascular disease and those with existing cardiovascular disease where the presence of CKM factors can impact care and also impact outcomes. Now, following from this definition came a staging approach for CKM syndrome. And the rationale for this is, number one, there's a progressive pathophysiology that's typical for CKM syndrome, and that's reflected in the staging. And what this does is it improves the identification of under-recognized clinical conditions that are often unrecognized, but still confer increased clinical risk. For example, 90% of those with CKD are unaware of that condition. As we move to higher levels of risk through later stages, we see the need for intensified therapies because there's greater absolute risk for adverse outcomes that justify doing a more intensified approach. Now, we focus on cardiovascular disease because this is the primary cause of premature mortality in this population. And there's another focus on kidney disease as well, but it's important to recognize that CVD is also the primary cause of mortality in CKD. Each of the stages represents a window for preventive intervention to prevent progression to later stages, and also it supports the concept of CKM stage regression with substantial lifestyle change and or weight loss. So these are the stages of CKM syndrome, going from stage 0, which is a no risk factor stage where we're focusing on primordial prevention, to stage 1, where excess and dysfunctional adipose tissue is the precursor to most of CKM syndrome. Stage 2, with a focus where metabolic risk factors and or CKD emerge from most of the time excess and dysfunctional adipose tissue. Stage 3, where there's subclinical cardiovascular disease or risk equivalents like very high risk CKD or high predicted risk. And then stage 4, where we have clinical cardiovascular disease that's overlapping with these prior metabolic risk factors and or CKD. And the goal, again, is to prevent CVD across this life course. And this is meant for not only adults, but also for youth. Because we recognize the need to personalize risk discussions, I also want to emphasize that we have risk-enhancing factors like chronic inflammatory conditions or a high burden of adverse social determinants of health. We talk about high-risk demographics. I know the First Peoples in Australia are one group where we see a higher burden of CKM syndrome. And then there's other factors as well, like sex-specific risk-enhancing factors and family history to be considered as you're personalizing your risk discussion with the patient. So I'll briefly talk about how we address cardiovascular kidney metabolic syndrome. I know my panelists, other presenters will be talking about some of these in more details. Number one, it's important to be thinking about social determinants of health. So we want to be doing systematic screening for social determinants, integrating that into our clinical workflow, having individuals on the care team, community health workers and care navigators who can better support addressing those, and leveraging community resources and programs for those with more adverse social determinants of health. Additionally, a key focus is interdisciplinary care models. So we know that there's a need for more collaborative care so we can prevent that care fragmentation I referred to. We put forth 2 different models, a value-based model where essentially there's support from interdisciplinary care team when we see a confluence of CKD, diabetes, and or subclinical and clinical cardiovascular disease, any 2 of the 3. And that interdisciplinary care team, of course, has the primary care physician at the center, but also the subspecialists, nursing, pharmacy, and the CKM coordinator. And the CKM coordinator's role is being to partner with PCPs and also to support patients in their journey to optimizing CKM care and health. There's also a volume-based care model for more high-risk patients where there's targeted referrals of high-risk patients to subspecialists. And then a CKM coordinator in that role is assisting with navigation among these multiple subspecialists with the use of telemedicine as needed for areas where there's a lower density of subspecialists. And there's a flexibility to rely more on a value or volume-based care model depending on the region and the clinical setup for that area. I want to emphasize that one thing we talk about a lot in the approach is thinking about not just pharmacotherapy, but also lifestyle change. And that combination having the greatest impact on outcomes. The STENO2 trial of patients with overweight, obesity, type 2 diabetes, and albuminuria demonstrated that using lifestyle change as well as targeted pharmacotherapy to reach glycemic, lipid, and blood pressure goals was associated with substantially reduced risk of mortality and also cardiovascular disease events. As my other panelists will be discussing, there are multiple CKM therapies that impact all these different axes of risk. SGLT2 inhibitors that reduce MACE, cardiovascular mortality, heart failure in particular, and reduce adverse kidney events. GLP-1 receptor agonists and other incretin analogs that induce marked weight loss, improve glycemic control, metabolic risk factors, decrease major adverse cardiovascular events and CVD mortality, and most recently in the FLOW trial, we're going to be seeing, for the preliminary results, a reduction in adverse kidney events as well. And then finerenone that reduces adverse kidney events in diabetes and also reduces cardiovascular events, primarily heart failure, largely via kidney protection. So we have a broader algorithm for thinking about CKM syndrome management, and it was broken down by the stages, reflecting, again, the fact that higher stages may have different focus areas. So some of the key highlights are, number one, addressing interdisciplinary care, where we see confluent risk factors, and also addressing social determinants of health. Particularly in stage 1, but then throughout, it's addressing obesity through the multiple modalities of lifestyle change, pharmacotherapy, and metabolic surgery, addressing and controlling CKM risk factors early, and then having a comorbidity-based approach to selecting those cardioprotective antihyperglycemic agents like SGLT2s and GLP-1 receptor agonists, and preventing CKD progression with the appropriate kidney protective agents, and more intensive and combination therapy in those with higher risk, such as those in stage 3 of CKM syndrome. Similarly, in stage 4, focusing on interdisciplinary care and social determinants, addressing obesity and cardiovascular disease, and here with the SELECT trial showing the impact of GLP-1s, considering pharmacotherapy as frontline therapy, addressing and controlling CKM risk factors, and then in those individuals with CVD and diabetes, being on antihyperglycemic cardioprotective agents, but then also thinking about combination therapy for those with very high risk or multiple comorbidities, and again, preventing CKD progression as another mechanism for reducing risk. I want to end with saying that there's a broad implementation focus, and this is going to be a big part of the AHA's focus in the next few years, considering social determinants, access to therapies, research gaps, interdisciplinary care models, supporting CKM education, enhancing obesity management, implementation strategies across centers, and then also thinking about how we support healthy lifestyle more broadly in communities. And our goal is to move to a patient-centered implementation focus, thinking about the various risk factors the patient is facing, the social context, and coordinated care approaches. So in summary, CKM health reflects the interplay among metabolic risk factors, chronic kidney disease, and the cardiovascular system. It's quite highly prevalent, has a disproportionate burden in those with adverse social determinants of health, and is linked to premature mortality. And fragmented care also impacts clinical outcomes in CKM syndrome. So the focus here has been talking about the definitions, staging approaches to promote prevention, overarching considerations of social determinants and interdisciplinary care, and then strategies for cardiovascular disease prevention and management linked to the CKM stages that reflect both harmonization across major guidelines and emerging evidence, and then finally a framework for better optimizing CKM health in the overall population. And I just want to thank all of those who are involved with the development of this guidance around CKM syndrome. Thank you so much.
Thank you. That was wonderful, and I really commend that scientific statement to people that want to know more. It was there's so much sense in there, and I apologize again for getting you up at 5 o'clock or getting you to talk at 5 o'clock in the morning Eastern time. And
it's my pleasure.
Rose to the occasion. We're going to move now to a case study that we'll be discussing throughout the rest of the meeting, and this is Rosa. And she's a busy office manager, works too long. She's an ex-smoker. She does have a family history of diabetes, and her father had heart disease. Working too hard also impacts the rest of her life. She has a few glasses of wine 4 nights a week, doesn't always eat right, doesn't get a chance to exercise except at the weekends, and probably doesn't sleep very well sometime anyway. I think we all know people like this. Her background is Italian, and she was diagnosed with hypertension and type 2 diabetes a couple of years ago. And that, interestingly, was probably related to the fact that she also had gestational diabetes during both of her pregnancies. She's on metformin at the moment and perindopril, and social. You can see some aspects of her social life there, but the important thing when we come to look at her risk is that her postcode was 3148. There's a list on your slide of the various tests and what's been found on examination. As you can see, her blood pressure's up a little bit. We won't worry too much about her cholesterol to HDL, as that's not a familiar number to you, but as you can see, her cholesterol is sort of okay, just up, but her HDL is very low. Her LDL cholesterol is quite high. HbA1c is high, 8.6%, and she's got an EGFR of 72, which we can think about what that means for a 58-year-old later. And she's somewhat overweight with a BMI, not overweight, obese with a BMI of 34.4. So keep that in mind with these presentations that follow. And we're just going to hear from our next two speakers first of whom is Elif, and she's an endocrinologist, and she's going to talk about the relationships between diabetes and cardiovascular disease. Thank you very much, Elif. You're muted.
Can you hear me now? Yeah?
Yep.
Thank you. So thanks for the opportunity to present. I'm a clinician scientist, and I do a lot of clinical trials at the Austin and University of Melbourne. And as part of that, I do my organisation, the hospital and the university, does receive funding from industry, and I'm also on advisory boards and do presentations, but those funds are donated towards diabetes research at my institution. So a bit of an outline to this. I think this is a really important area, and thanks very much for Chiadi for a lovely introduction to this. So I'm going to talk a little bit about GLP-1, incretins actually. I'm going to talk about incretins as a class, because you're going to hear more and more about this. And this is probably one of the most important groups of drugs that we've had since insulin was invented over 100 years ago now. There's also the SGLT2 inhibitors, but you'll see what I mean by the importance of these drugs in terms of clinical trial data, as well as potential cardiovascular and renal benefits of these drugs. So talk about mechanism of action of these. I'll talk about the trials in type 2 diabetes, a bit of a summary, trials in obesity, and looking at the cardiovascular outcome trials in particular. And then if we have time, I'll talk about real world studies. So the incretins, or endocrine hormones, are essentially, an important discovery which was made after realization that when an oral glucose tolerance test was given, that the insulin that was released, as opposed to an IV glucose load, was a lot greater. And after some work, it was discovered that they have an effect, multiple effect, as you know, on insulin secretion, appetite, intestinal motility, lipid homeostasis, as well as more recent evidence potentially on the gut microbiome. And you can see a bit of a summary here, and this is with credit thanks to Nupur, who's one of our diabetes fellows. And you can see that it's actually not just one hormone, but multiple hormones that are released after a meal to help our body with its metabolism. And the particular interesting ones, GLP-1s, GIP, as well as glucagon, and I'll show you some of the data that's coming out through the clinical trials. And so this is a very rapidly evolving field, and I'm going to introduce the concept, because you've heard about GLP-1s, that's Ozempic, semaglutide, Trulicity, we used to have Bydureon and Byetta, but the tirzepatide, which is an important medication, or Mounjaro, that that our patients are using, that it's currently not on the PBS, however, it's widely available and people are using it for, it's actually TGA approved for diabetes. And is based on actually two hormones, and the molecule is a peptide, which is GLP-1 and gastric inhibitory polypeptide, which is GIP. And GIP, as a bit of an introduction, we're realizing the importance of this, and it's interesting because we don't fully understand whether it's the antagonism or the agonism of it that is having its effect, and so further studies will follow. But certainly it is having an effect on satiety, on pancreatic function, thermogenesis as well. So some data showing effects on thermogenesis, and on lipid metabolism and inflammatory signaling. And the other incretin that's coming around the corner is other glucagon incretins that are in combination with GLP-1 typically. And glucagon itself is also showing, we're discovering that it is having an effect on gut motility and satiety, as well as potential effects on the kidney, but importantly on metabolism as well. And there's also some evidence coming through that it is having an effect on liver metabolism and energy expenditure and lipolysis. And perhaps this is a complex slide, but I just want to show you how much is evolving in this space. And I do a lot of clinical trials here. Actually, in fact, we do almost all the clinical trials that are listed here of these agents. And what is interesting is how rapidly it's evolving. So if you look at GLP-1, which is, we commonly use, semaglutide that we have here, or Ozempic or Trulicity, when that is combined, so these are just the GLP-1s, you can see semaglutide, liraglutide, dulaglutide, that's what we have here. When it's combined with GIP, it is tirzepatide, that's Mounjaro that we have available, and there's also trials that we're doing with survodutide in combination with glucagon, and actually there's one drug which combines GLP-1, GIP, and glucagon, and that's called retatrutide, and that's an important drug that's also, I'll show you some slides. But not to complicate this too much, but just to say that this is a very rapidly evolving space, and that we're getting some really good clinical trial data coming through, which is great for our patients in the future. So bit of an comparative efficacy. And what I meant by this is, probably one of the most important discoveries since insulin is in terms of its efficacy of glucose lowering. So we saw with semaglutide, some time ago in 2017 with the SUSTAIN trial, that this drug had a significant, less than more than approximately 1.6% reduction in A1C. At that time, we saw weight lowering effect of around 6.1%. We are now with tirzepatide, we're seeing much more greater reductions in A1C, and this is sort of the next cab off the rank. And with survodutide, which is the GLP and glucagon agonist, similarly, this is a very highly efficacious drug we're doing clinical trials at the moment. And more interestingly, the triple G, which is retatrutide, is showing even more greater reductions in A1C and weight lowering. And it's been recognized that there is potential anti-atherosclerotic benefits of these drugs. However, it's fair to say that this is mostly, this data is mostly gained from animal studies. And this is an example of one where there was some attenuation of the plaque lesion area in mouse models of atherosclerosis, and it was thought to be independent of the dose. And so compared to the controls, that the animals that were having the semaglutide had less plaque lesions in their blood vessels. And this is also a summary showing that in terms of, it's possible that they're having multiple effects at different areas, and these are highlighted the greens, where these GLP-1 receptor agonists may be having an effect. However, it's difficult to know whether all these are also related to the fact that people lose weight. And with weight loss, with loss in fat, and with blood pressure lowering, glucose lowering, obviously there are benefits in terms of atherosclerotic effects. And so what about the evidence thus far? And I want to focus on these trials because they're really important trials. And for diabetes, you may have seen some of these data, and then I'll talk a little bit more on the obesity trials because there's a very important trial that was recently published, the SELECT trial, which I think it's very important for people to know about. And so this is a nice summary here. You can see that, in fact, it summarizes all of the cardiovascular outcome trials of GLP-1 analogs in people with type 2 diabetes. And these are sort of hard endpoint clinical trials. So they looked at the cardiovascular outcome events. Typically, it was a MACE, which is a combination of a composite of death from cardiovascular cause, non-fatal myocardial infarction, and non-fatal stroke. And there are some MACE endpoints that also include things like hospitalization for unstable angina as well. But you can see all the green highlighted are the trials that were done actually some time ago now, that have been published showing that these drugs are superior versus placebo. So that's liraglutide, semaglutide, which is Ozempic, albiglutide, dulaglutide, which is Trulicity, and this is what we have in Australia. You know, Saxenda is liraglutide, Trulicity is dulaglutide, and Ozempic is semaglutide. And I think it's important to note that that there is SOUL clinical trial as well as SURPASS, which is looking at tirzepatide cardiovascular outcome trial. So one of the things that happened is the mandate, you know, there's a mandate for clinical trial evidence when new therapies are brought to the market, to make sure that they're safe. And so the benefit of that is meant for us a really great deal of evidence for our patients, which is great. And I think it's important to watch out for the FLOW trial that Chiadi mentioned. And in this trial, it was a trial comparing semaglutide, the 1 milligram dose of Ozempic or semaglutide, and it was a placebo-controlled trial. And what it showed was that there was a 24% reduction in the risk of kidney disease events in people with type 2 diabetes. And this trial fully hasn't been published, but the trial was stopped early because of the beneficial effects of the drug on kidney function. And the outcome was reduced kidney disease progression, MACE, and death. And so this is an important clinical trial to watch out for, and it should be published soon. And Chiadi mentioned, but this is sort of the latest guidelines, and it looks complicated, and this is what the American Diabetes Association and the European Diabetes Association recommend for our patients with type 2 diabetes. But it's important to note that the social determinants of health is being recognised, which is really important. And finally, it's great that guidelines are incorporating this information, as well as the emphasis on obesity. But, you know, in people with atherosclerotic cardiovascular disease, it's really around ensuring people receive this and these beneficial drugs like the GLP-1 analogs, like incretins or SGLT2 inhibitors. And I think the focus on weight management is really positive and important for our patients. And there's a lot happening also in obesity, and this is really great. So the one trial that I need to talk to you about, and it's really important that you know about this, is the SELECT trial that was published late last year in New England Journal. And this is a trial where, we participated in this trial at our centre, and we randomised people to up to 2.4 milligrams of semaglutide. So the usual dose of semaglutide that we have in clinical practice is 1 milligram. And they were also randomised to placebo. And these were people who were overweight and they had a prior history of cardiovascular disease, but without diabetes. And the endpoints was the 3-point MACE, which was non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. And so the other important information I think here is it's a good completion, 97% trial completion, which is really good. And the numbers are big too, 17,000 people randomized. So I think that's really important trial for us to know about. And in this trial, the primary endpoint was the cardiovascular, the MACE endpoint. And this is a nice summary of this endpoint. And you can see here that there is, in the people who received semaglutide, that there was 20% reduction in MACE, so death from cardiovascular cause, non-fatal myocardial infarction, and non-fatal stroke. And the follow-up time was 40 months for this trial. And this was associated with a significant change in body weight in the order of 10%. The other thing I think is important to note is that there are gastrointestinal side effects of these medications. And, and this is significant, like there's 16% of people who had experienced gastrointestinal side effects and actually discontinued the medication. So I think that's important. But I think it's also nice to see really nice data showing that there was no difference in terms of neoplasms here compared, this is semaglutide compared to placebo. And it's really nice to see these data in 17,000 people. The other trials that are happening, and we're participating, I'm the national lead for this synchronized trial, which is looking at in people with obesity. and type 2 diabetes, but the cardiovascular outcome trial is looking at people who, the long-term cardiovascular safety in people with obesity, in people with pre-existing CKM. And so we need to watch out for that one. The other one is the tirzepatide cardiovascular outcome trial. Again, we're participating in this trial. This tirzepatide, as I mentioned, is the Mounjaro, which is a combination of GIP and GLP-1. A highly effective drug, and there's a nice cardiovascular endpoint trial to watch out for that one as well. So I think it's fair to say that these drugs are here to stay. They're really, they're as I showed you the slides from terms of diabetes outcomes, they're really efficacious, and I think that they're really great in terms of glucose lowering and weight lowering. And I think the other benefits is that we didn't have these drugs, we didn't like SGLT2 inhibitors and GLP-1s. And I remember as a registrar and as a young consultant how hard it was to manage the cardiovascular risk factors in our patients, and the blood pressure levels were high because a lot of people were on insulin, were obese. And now we can actually get people off insulin, typically with these drugs, and help them lose weight and get, typically they have more of an opportunity to participate in day-to-day, physical activity, and can sleep better and so forth. I think that the cardiovascular benefit in diabetes and obesity, the trials coming through are really important for us to find out about. These are big deal clinical trials to find out and read about. They've got good safety profile. However, they're not always tolerated in everyone. There's a 16% intolerance in select. And there's also other issues like, you may have heard about, people not just lose weight, but they also lose muscle tone and muscle bulk as well. There's also the ongoing issues with access and costs, and that's more significant in people who are unfortunately from lower socioeconomic groups. And I think it's fair to say it'll be really nice to look at some long-term real-world evidence. And I think I need to stop now. So thanks.
Oh, you could go on, Elif, because that was wonderful, and had such an exciting time in the diabetes world and the crossover into obesity, cardiovascular disease. And now we're going to hear about the kidney. And Karen Dwyer is going to lead us into that discussion. Thank you, Karen. But before you start, can I just remind the audience, we'd love to get questions from you. Put them in a chat box, whatever occurs to you, and we'll deal with as many as we can at the end of the presentations.
Great, thanks. So I hope you can all see my slides. So I will be talking about CKM, but specifically through a kidney lens. It's just not advancing. Sorry, I'll just get that to advance properly. Oh. Okay, so like Elif, just want to disclose that I do receive some industry support, and like Elif, it's used for research funding, and my current funding is listed there through some funding bodies. So I just wanted to reiterate what CKM means in the Australian context. And at least around 30% of Australians have at least one of cardiovascular kidney disease or diabetes, and that equates to 5.6 million Australians. And as you can see, there's certainly some overlap, and so some are consequential, but they can exist side by side, and that really highlights the common pathophysiology. And why is this important? Well, we know, and as has already been stated, the most disadvantaged are disproportionately affected by CKM, and this includes Indigenous population in Australia, the Aboriginal and Torres Strait Islander peoples. We see that CKM occurs at a much younger age and progresses in a much faster fashion. And this is important because 1 in 3 hospitalisations are due to diabetes, cardiovascular disease, and or chronic kidney disease. And it impacts the individual through psychosocial factors such as depression, lower quality of life, and cognitive impairment. So traditionally, we've thought of the risk factors for kidney disease being diabetes, hypertension, the central adiposity, and heart disease. But as highlighted earlier, that's really the tip of the iceberg. And if we move upstream, there are a number of overlooked risk factors, and these include prediabetes, hyperuricemia, metabolic associated steatotic liver disease, and metabolic syndrome. And as highlighted in the first talk, that this is all stemming from dysfunctional or excess adipose tissue, which we know is causing hyperinsulinemia or insulin resistance. So this really is the root cause. And in kidney disease, we see insulin resistance appearing very early, even with a normal EGFR, and is essentially universal in those that progress to kidney failure. And if we have hyperinsulinemia, so if we've got dysfunctional adipose tissue, we've got hyperinsulinemia, which coexists with insulin resistance. And the impact this has on the cells is that some cells are unable to signal, so they become resistant, but some cells remain able to signal, and they're overstimulated due to hyperinsulinemia. So if we consider hypertension, for example, we have overactivation of the sympathetic nervous system, activation of the RAS, which leads to sodium reabsorption. And then on the other hand, we have insulin resistant at the vascular level where the vessels are unable to produce nitric oxide. And so we have vasoconstriction. So you can see that so-called essential hypertension really is underlying insulin resistance and hyperinsulinemia. What about within the kidney? Well, we know from animal studies, again, that insulin signaling is critical for normal kidney function. There is a mouse that is insulin resistant just in the kidney. So this is the podocyte. And in this animal, so the insulin resistance is purely at the level of the kidney. The blood glucose in the mouse is normal, whether it's a wild type or one of the insulin resistant mice. However, these mice develop renal disease at a very early age. So they develop albuminuria at 8 weeks, and by 13 weeks, they have the changes consistent with diabetic nephropathy, despite having normal blood glucose levels. And you can see that the kidneys in panel F are shrunken, as we would see in someone with chronic kidney disease. Further, in vitro studies showed that insulin directly remodeled the podocyte, and highlighting the critical importance of insulin sensitivity at the level of the kidney. So given all that, how do I manage someone with CKD in the context of CKM syndrome? So the first thing I do is I assess for insulin resistance and hyperinsulinemia through paired fasting insulin and glucose levels, calculate a HOMA-IR, look at hemoglobin A1C. I then look to optimize insulin sensitivity, and this is really drilling down on the lifestyle factors that were discussed before through diet, activity, sleep, stress, and of course, smoking cessation. Diet is perhaps the most pervasive element in terms of insulin resistance, and therefore a prime target for insulin sensitivity. And my approach is to ensure that we're getting high quality protein and minimizing carbohydrate. We know from other studies that certainly lowering the carbohydrate, which stimulates insulin secretion, can have a profound effect on blood pressure, with a very significant reduction in both systolic and diastolic blood pressures and deprescription. Activity is really important, and we know again increases insulin sensitivity, and the importance of resistance exercise can't be underestimated. The muscle is the most metabolically active organ and is really important for promoting insulin sensitivity. Chronic sleep deprivation leads to insulin resistance, as does stress, and I've mentioned smoking already. We mentioned earlier the impact of CKM on First Nations Australians, and kidney disease is probably is a very striking example. So the prevalence of chronic kidney disease in Australia is 1 in 10. However, the prevalence in First Nations Australians is double that, at 1 in 5. And in some areas of Australia, particularly Central Australia and in the Northern Territory, chronic kidney disease can reach prevalence levels of over 30%. And this data is now many years old, but but showed that both type 2 diabetes and hypertension increase as BMI increases as a surrogate for insulin resistance. And this is evident in young people between the ages of 15 to 34, but also in older people over 35. The same group showed that 7 weeks of a traditional diet led to a reduction in fasting blood glucose and insulin, with heightened insulin sensitivity and improved glucose disposal, again showing the importance of diet in tackling CKM. This group went on to try and propose a theory as to why they saw these changes. And a Western diet, as we know, is very high in excess energy and refined carbohydrate, and people are more physically inactive than previously, and together these lead to insulin resistance. But on a traditional diet, which is high in protein and low in carbohydrate with high physical activity, this does promote insulin sensitivity. And I'll just also highlight there that there is this area of famine which introduces the concept of intermittent fasting or time-restricted eating, which there's significant evidence now that this does improve cardiometabolic health through a number of pathways as indicated. Blood pressure again reduces very nicely with time-restricted eating or metabolic or with intermittent fasting, and it has been shown that this is due to some changes at the level of the gut microbiome. So after assessing and optimising for insulin resistance using lifestyle measures, I then look at adjunctive pharmacotherapy. And now we talk about a 4-pillar approach to the management of kidney disease. We have RAS blockade, which for many, many years now has been the backbone of management for chronic kidney disease. SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonists, and the GLP-1 receptor agonist, which I clearly won't go through given Alif's excellent presentation. We know a lot about the RAS blockade, that they offer both renoprotection and reduce albuminuria. The SGLT2 inhibitors have really transformed care for kidney disease and has been rapidly incorporated into guidelines. The big trials, which are all listed there, have looked at kidney disease in the presence and absence of diabetes. And with the presence of proteinuria and chronic kidney disease, all over and over, we have now seen that SGLT2 inhibitors slow the progression of chronic kidney disease. And you can see from both of these graphs with 2 different SGLT2 inhibitors, some modelling whereby the introduction of the SGLT2 inhibitor really slows the rate of EGFR decline, which extends the time to reach kidney failure. And in the top graph, you can see that the earlier that this is introduced, the greater the impact, with a definite sort of blip at around that 30 mils per minute. So we want to be introducing these agents as early as possible and maintaining them even as EGFR declines. Just a little bit about the non-steroidal mineralocorticoid receptor antagonist, and this new agent is called finerenone. If we think about chronic kidney disease in the context of type 2 diabetes, there are a number of mechanisms at play. We have the metabolic mechanisms, hemodynamic through blood pressure, and then inflammation and fibrosis. Our traditional therapies have really been directed towards the hemodynamics and the metabolism. So the uses of RAS blockade, ACEs and ARBs, and the SGLT2 inhibitors, and then the metabolic, so SGLT2 inhibitors, the GLP-1s, and of course not forgetting metformin. But inflammation and fibrosis hasn't really been targeted. And this is where mineralocorticoid receptor overactivation may be contributing to CKD progression. And this is where finerenone plays a role. So finerenone is a non-steroidal MRA as opposed to the steroidal MRAs, and spironolactone is the most common. There's been a number of trials now looking at the role of finerenone in CKD. And as you can see, these have targeted people with moderate to severe kidney disease with varying degrees of proteinuria. And there's the Figaro and then Fidelio, and these have been pulled into Fidelity. Now, if we look at the impact of these agents on cardiovascular and kidney outcomes with finerenone, we can see, similar to what SGLT2 inhibitors, that there's some protection with these lines diverging sort of around that 18 to 20 month mark, which is a little bit later than what we see in terms of with the SGLT2 inhibitors. But regardless, we do see a reduction in the risk of progression of CKD. And similarly, with the cardiovascular outcomes, again, there's protection. And this is principally through a reduction in heart failure. So how might this actually look in clinical practice? And I just wanted to highlight a calculator which is called the kidney failure risk equation, which is available online. And you enter 4 variables. And let's take a typical person who is 78 years of age, is of male gender, with CKD stage 3, eGFR of 36 mils per minute, and macroalbuminuria. You put these figures into a calculator, and it will give you an estimate of the risk of kidney failure over the next 2 or 5 years. And over the next 5 years, this particular individual has a risk of about 10%. And then we can see what would be the impact of these of doing various therapies and trying to adjust that risk. So, for example, just by achieving good blood pressure control, we can reduce the risk from 10 to 8%, using RAS blockade 10 to 7%, an SGLT2 inhibitor from 10 to 5.5%, and finerenone 10 to 7%. And of course, putting these together, these can certainly add up over time. So to summarise from a CKD perspective and to build on on what's been already said, I think it's really important to test and to be on the lookout for the presence of insulin resistance and hyperinsulinemia, and this due to this dysfunctional adipose tissue, which is often that visceral central adiposity. The non-pharmacological measures are absolutely foundational, and if we want our pharmacotherapy to work very effectively, we do need to think about high quality nutrition, high protein nutrition, resistance exercise, adequate sleep and stress, and of course, no smoking. And then thinking about management of renal disease in 4 pillars: RAS blockade, SGLT2 inhibitors across the board, non-steroidal MRAs in the setting of type 2 diabetes, and currently GLP-1 receptor analogues with diabetes. But as we await the FLOW trial, as already mentioned, that may also change. And then we need to continue to monitor CKD, and that's through targeting blood pressure of less than 130/80, regular blood tests looking particularly at the eGFR, and of course following albuminuria. And most of these agents, or all of these agents, have their profound effect through reducing albuminuria, which is one of the most potent risk factors for cardiovascular disease. Thank you.
No, thank you. That was great. And now we're going to go back to to poor Rosa, who's been waiting for us to see what we're going to do about it. And Garry Kiloff is going to introduce the discussion on Rosa a little bit further.
Thank you very much. So you've already met Rosa, but I think it's not a bad idea to just recap. We have a patient who I suspect many would be able to relate to. We'd have patients very similar to Rosa in our practices. So she's a middle-aged office manager working very long hours. She was a smoker. We're not told how many pack years, but she did see the light and quit 7 years ago. She has a very strong history of type 2 diabetes with both parents, and her father succumbed to a major adverse cardiovascular event. And of course, our expert speakers have all alluded to this interplay between the metabolic and, of course, other outcomes. Her lifestyle, again, works, I think Garry said, works too long, works too hard, and perhaps relies a little too heavily on ethanol to wind down from Thursday night to Sunday. Her dietary habits are perhaps suboptimal, and sometimes you just do what you got to do. She has an Italian background, and she has been diagnosed with a number of markers of metabolic syndrome and insulin resistance, hypertension, type 2 diabetes, and she declared her insulin resistance a long time ago, having gestational diabetes with both of her pregnancies. Current medications are fairly standard, but as you will see from her biochemistry and her anthropometrics, that perhaps we could be intensifying things a little bit. Social background, she, as we said, she has a job, which is great. She lives with a husband and an adult child that I'm assuming both parents support, as he's, well, we don't have to say he or she is a student at university. So hypertension that is suboptimally controlled, lipid profile that is very typical of the dyslipidemia we see in metabolic syndrome, with low HDL, raised LDL. We don't actually have triglycerides, but it wouldn't surprise me if the trigs are up as well, given both the hyperglycemia and the dyslipidemia. eGFR of 72 is certainly going to raise some concern in a 58-year-old. And as mentioned already, she carries excess adiposity, knocking on the door of class 2 obesity. So certainly a number of risk factors for cardiometabolic outcomes, which we know the majority are going to be cardiovascular. 2/3 of our patients with diabetes will succumb to a major adverse cardiovascular event. And we are also seeing some signals of renal dysfunction. So where to with Rosa? We have, I think, some questions, a poll to get your views on what you might do and whether you consider her to be at significant risk or not. So make your selections now, and we'll then have a chat about it. So I think we get the sense, and certainly I would be surprised if we didn't generally feel that we were intermediate to high risk, based on the discussions covering the lipotoxicity and glucotoxicity and the overall overlap of these conditions that all add risk in a more than additive way. So is there a better way to determine her risk? Is there something else we could do? So as you all know, we've got a new shiny, probably not so new shiny, risk calculator anymore, available to everybody as an online calculator. And if we enter Rosa's details, we can see that she comes up with a 10% risk of a cardiovascular event in the next 5 years. So this puts her in the high risk category. So certainly most of our delegates have picked this spot on. And I think the heuristic, the general sense is that this lady could be in serious trouble, and she's not old. She's a young lady. So we would certainly want to be fairly aggressive about managing these risks And you've seen a number of slides on the benefits of various interventions in prolongation of life and prolongation, more particularly, of healthy life. And next. So how would you explain this to Rosa? We know that Rosa is going to be engaged only if we can make sense of all of this to her. And going back to, again, a number of the presentations that we've had about the importance of a person-centered holistic care. So you've now convinced Rosa that treatment's necessary. What is it that you're going to choose? And of course, you could choose multiple things, but in this situation, I think you're only able to choose your favorite, which we know that in the real world, this may not be the case. So an interesting spread, with the most popular being the diabetes medications. And I think I can see why these make sense, because these really are glucose-lowering agents with many, many other benefits, with cardiorenal protection. We used to think of SGLT2s as the drugs for heart failure and kidney disease, and GLP-1s for atherosclerotic cardiovascular disease. But more and more, we are seeing that there's overlap in terms of the benefits of these agents. So if you only could choose one, I can absolutely see the rationale for that. I suspect that in the real world, we would be using a combination of these agents, because Rosa, we need to address her hypertension. So, amlodipine, adding amlodipine CCB to her ACE inhibitor makes sense. We need to improve her glycemic control. So the SGLT2, GLP-1, in addition to her metformin, makes good sense. She has class 1, almost class 2 obesity. So both SGLT2s and GLP-1s in particular are going to address that. So certainly a great combination, and statins are going to be, of course, your go-to agents for dyslipidemia. You may add a fibrate later, you may need to do other things, but certainly statins would be your first port of call. So yeah, I think by and large, we would all be in agreement. So we could perhaps close this, and now what I'd like to do is really to perhaps put the same question to our panelists. So I might actually start with Professor Elif, if I may. How would you optimize Rosa's diabetes management?
Yeah, thanks. Just a couple of things I wanted to mention is that unfortunately we didn't see a urinary ACR there. And that's, I think, really important for us to think about and order, because there's some data showing that people aren't ordering this test. And really, it's very important test actually for us, because if that person had albuminuria, any level of albuminuria, that would really push, the direction towards SGLT2 inhibition initially. And I think I just want to highlight that, please order ACRs, because things aren't getting ordered, and then we miss these really high risk people, right? So I think in this situation, she needs something, and access to GLP-1 analogs has been an issue. So it just depends on in her suburbs. I mean, there are some suburbs in Melbourne where I live where you just can't get these drugs. And someone like Rosa would really benefit from, introduction of GLP-1 analog, because she's got a BMI of over 35, I think. And that actually would limit her physical activity, limit her sleep. Obviously, the issues that Karen talked about are really important in terms of lifestyle and exercise. But sometimes losing a little bit of weight actually gets things going for a lot of people in my clinical experience. So if Rosa could go to a pharmacy and could find Ozempic or Trulicity, I would push for that initially to help her with the weight loss. I think that would help her blood pressure as well as her other cardiovascular risk factors.
Thank you. Given her A1C, would one agent get her to target, do you think?
Yeah, look, in clinical trials, we've seen with the full dose of Ozempic, the A1C reduction of the 1 milligram doses, around 1.2, more than 1.2. With the higher doses of the semaglutide or Ozempic, it's high, but we don't have the high dose Ozempic in Australia. Certainly, I think it will bring it down to the mid-7s, and she may need additional agents, but with some lifestyle changes. I couldn't remember whether she wasn't on diamicron, was she? No, I don't think so. That's good. I mean, we have a restriction in terms of, the combination of SGLT2 inhibition and GLP-1 in Australia. It's not possible to access the combination unless some people pay for them privately. Yeah.
Thank you. And this really follows from what you were saying, and I think to some extent you have answered it. But I might ask Professor Ndumele to talk about this, and that is, how would you help her achieve a healthy weight, and which as we've seen, getting rid of the excess adiposity has so many benefits. If we had a pill that did what weight loss did, it would be a blockbuster. How would you go about optimizing the weight management here?
That's a great question. And I think it's important to emphasize how, in this case in particular, how central this excess and dysfunctional adiposity is to so many of this metabolic abnormalities we're seeing in this patient: the blood pressure, the marked atherogenic dyslipidemia, the high insulin levels, and probably also some of the kidney impairment. So I think the weight loss here is particularly important and has the potential to induce some CKM regression in this scenario. So I do think that, this is a scenario where, people have asked a lot of these questions about lifestyle, pharmacotherapy, and should it be one or the other? And I think we need to be moving the discussion to and versus a discussion of or. And I think the SELECT trial was very helpful in this regard, because in SELECT, different population with existing CVD, it wasn't a trial of weight loss. They just gave the medication. And with that, we saw about a 9% average reduction in weight. But if you do this lifestyle support, even remote lifestyle support with the medication, we actually are seeing more than 15% in terms of weight loss in the STEP 1 trial. So it really just indicates the importance of combining those two modalities together. So this is a scenario where I think there needs to be a helpful, non-judgmental weight loss discussion, kind of introducing this as a central aspect of risk, and kind of basically engaging her on whether or not this is something that she wants support for. And then I think the way to kind of induce this is really through some behavior change. So it's basically having constant support. We have multiple mechanisms for doing this. I personally work closely with some of our weight loss or integrated weight loss clinics, but just giving ongoing support for weight loss plus the pharmacotherapy. I think with that, as was said, we would get benefits on multiple aspects of these metabolic arrangements here.
Yeah, that's great. Thank you very much. And thank you again for reiterating the vital importance of optimizing lifestyle, because it really is the bedrock upon which everything else is scaffolded. And it's one thing you'd aspire to avoid chronic disease, let alone if you had it. So I think that should be something we aspire to throughout our life journey. Professor Leaf, I think you've got your hand up.
Just a quick comment. Just don't forget the two important lifestyle trials that we have had. For the Look Ahead trial actually was in people with type 2 diabetes, and in those people who did lose weight, they did actually have cardiovascular benefit. Not in the whole population, but just shows that it is hard to maintain lifestyle. And the other one obviously is the diabetes prevention trial, where people within that obese category, the lifestyle things actually do work better than metformin. So it's really want to highlight that.
Yes. I'm going to make one very quick comment just to piggyback on that. One of the lifestyle works quite well, but the challenge with lifestyle is that we see that our body tends to do a very significant metabolic reset after we lose weight that leads to a lot of weight regain, weight recidivism. The benefit of these therapies is that it doesn't seem to lead, when you're taking them, lead to the same weight recidivism. We have kind of a significant continued weight loss and then a plateau that is maintained while you're on the medicines. So the lifestyle piece in combination is very helpful, but these medications prevent that metabolic reset that we so often see that leads to that weight yo-yoing for individuals when they're trying to do it all on their own.
Yeah, no, thank you. That's wonderful. And now for Professor Dwyer, and this is probably a bit of an unfair question in terms of what renal therapies you would consider, because we do have an information deficit, as Professor Leaf pointed out. We don't have an ACR. So I'm going to do it as a kind of sliding doors question. On the one hand, if the ACR is within normal range, and secondly, if the ACR, and you can pick a number, is moderately elevated and has been confirmed on several samples.
Yeah, thanks for that. So I think if with or without proteinuria, optimization of blood pressure would be really good here. So if there was no proteinuria, you may consider adding in a second agent, because we know those combining agents can be quite powerful. Blood pressures are not grossly elevated. There is it at 150 on 92. If there was some proteinuria, I would be recommending that we maximize the ACE inhibitor. So you really want to drive that up to maximum dose, and that helps. That gives us the best chance of reducing albuminuria. If there's persistent albuminuria, then that would open the door for SGLT2 inhibition. And PBS listing currently is for urinary ACR in that sort of borderline micro to macro albuminuric area. Although we do know from some other studies that the effect does work across a range of eGFRs and degrees of albuminuria, but it's most effective with more albuminuria, which just really shows the importance of albuminuria in driving both progressive kidney dysfunction, but also cardiovascular disease. So maximize RAS blockade first, then look at SGLT2 inhibition.
Excellent. And this is one situation where, in fact, she could access both GLP-1s and SGLT2s, not for glucose lowering, but the SGLT2 would be for kidney disease, and the same applies where there's heart failure. If people meet the criteria, they can quite legitimately get GLP-1 and SGLT2 on PBS. Thank you. That's great. And I'm not going to leave our facilitator in the dark here. So, question for you. Rosa then goes on to develop cardiovascular disease. Let's say she's had an infarct. Are there any things that you would do differently with respect to the conversation that's already taken place?
Very little. We'd be adding aspirin or managing her coronary disease according to the appropriate ways. But beyond that, we've now got new indications both for SGLT2 inhibitors and GLP-1 agonists, and we certainly should be considering that. I don't know whether we put her on a statin in the first case, but we probably would. We certainly would. But otherwise, it would be exactly as it's been discussed, unless anybody else. I mean, I'd be interested if there are any other thoughts.
So it is a happy coincidence, if you like, that whether we're looking at cardiovascular disease, kidney disease, obesity, we are coming back to the same agents. And of course, not surprising, because the pathophysiology that drives all of these is very similar. But I guess the message for the delegates is that whilst some of those presentations, very detailed, beautiful presentations, seemed complex, in reality, we keep coming back to the same agents. So in that sense, the heuristic is you're going to be looking for SGLT2s and GLP-1s for many of these conditions. And as Professor Leaf mentioned, we're really just at the starting blocks. There's a whole range of agents on the horizon that are going to define the space over at least the next decade, I would imagine. So thank you very much.
Off the hook quite so easily, Gary, because I've got a question for you. We've got a lot of new drugs, we've got a lot of tests. As you've mentioned, we've got a number of conditions. How do you handle it in general practice? How do you get to treatment targets? How do you identify these people early? Because we know it really, these systems that we formally assess for chronic kidney disease or for cardiovascular risk in their 40s really start much earlier in life.
Absolutely. And look, I'd be lying if I said there was a simple answer to this or an easy answer to this, because we know, unfortunately, no matter what condition we look at, therapeutic inertia is alive and well. So we need to recognize, firstly, that we could be doing things better. And we do have some enablers and perhaps some barriers. So one of the great things is our opportunity to interact with our patients, both longitudinally, in the sense that we will see them many times, build relationships, and that gives us many opportunities. Also, keeping in mind that over 80% of the population will see their GP at least once in a year, and those with multimorbidity or comorbidity will see them more often than that. So just keeping in front of mind that, could we be doing better with this particular individual, or should we be screening them for conditions that they are as yet not presenting with, is I think, if we can habituate that would be very good. Another alternative, of course, is that we can actually formalize the process. We can do recalls, we can do database searches, and now I think a vanishingly small number of GPs would not have electronic records. So, the clinical audit tools will allow you to search by diagnosis, by therapies. So you might do an audit on statins. Should this patient be on additional medications? Should they be screened for metabolic associated fatty liver disease, and so on? The real challenge is that whilst this all makes very good sense and is a good idea, we're all very time poor. Patients presenting will have agendas of their own. So how you make that happen, I think, is about keeping that front of mind, educating the patient. Why would we want to do this? What's in it for you if we were to screen for these additional things? So nobody wants to go into the doctor coming out feeling worse than when they went in, being given all these diagnoses. But I think if we can engage people and get them to understand the potential seriousness of not engaging versus the real benefits of engaging, that's the conversation. Again, going back to this issue of personalized medicine. And I think this is what GPs do very, very well. How we find the extra time and resources, that I'm not sure about.
Well, you're time poor and we're time poor too, because
Yes.
Because we've only got a few minutes for a large number of excellent questions. I'd just be interested, before we leave that though, Chiadi, you talked about the team-based care, and that's clearly the one way in which we can help the general practitioner. What do you see as the essential ingredients of the team, or what did your...
I think as Gary, the other Gary just said, it's really this is a role that PCPs, primary care physicians, have been playing for quite a while. Like, they've been at the center, they've been thinking about the whole patient for some time, but there's a need for that support. And I think we've seen over and over again that having some coordinating support that partners with primary care clinicians makes a really big difference in really helping individuals get to goal. We've seen it in getting people on multiple pillars of therapy for heart failure. We've seen it in other kind of states where there's more complex therapy. So I really do think that having those coordinators for CKM Health that can partner with primary care clinicians, nurses and pharmacists will make a big difference in this regard. I suspect there's also, as Gary just said, also going to be a role for technology, where we can make some of these things a bit more automated and provide a bit more support in that regard as well. But I do think that additional support is helpful, with the primary care clinician really guiding the patient-centeredness of the approach in terms of understanding where we're going to prioritize our efforts.
I want to come back to the technology a little bit later, but Garry did mention non-alcoholic fatty liver disease, and I'm wondering whether you're, in your position statement, scientific statement, you considered including that.
Yeah.
Where do you think these various treatments come in? I know the acronym would have been far too long, but what?
Yes, so MASLD is very important. So that's really, as people probably know now, at least in the U.S. and I'm sure elsewhere, the leading cause of cirrhosis, and quite intimately related to this CKM syndrome components. And so it was in our conceptual diagram, because what happens with fatty liver is that it does lead to more inflammation, more insulin resistance. It potentiates a lot of these pathophysiologic processes. However, in the staging, everything that's included in the staging construct are all factors that are causally linked to the development of cardiovascular disease, and for which addressing those reduces risk of cardiovascular disease. Even though fatty liver is quite important and is a target, and addressing CKM syndrome will have positive effects for fatty liver disease, both the interventional data and the Mendelian randomization genetic data don't support a causal impact on cardiovascular disease. It's associated very strongly with cardiovascular disease. So as a result, there's, I think we're going to have many benefits. Even these GLP-1 receptor agonists seem to be having a substantial impact on fatty liver disease, certainly everything else we're talking about, but that's the reason why it wasn't in the actual staging construct itself.
Fine. Now, I've got a number of questions about the drugs that we've been talking about, and I'm going to ask them all at once and allow Alif and Karen to divide them up amongst themselves. One is about the role of aspirin in CKM. Another one is, should we be switching people from spironolactone to finerenone in people with CKD? Is there anything in particular that helps you identify people that are going to have GI side effects with GLP agonists? Is there a dose-dependent relationship between GLP-1s and cardioprotection? And a little bit about the urogenital complications. All of these are important and good questions, and please feel free to pick up on any of those things.
I can jump in on the finerenone question. So it's a tricky one, isn't it? So it really depends on the patient in front of you. So if somebody has cardiac failure, for example, spironolactone is a pillar in the management of cardiac failure, and in that sort of setting, I would not be switching somebody to finerenone. The ongoing studies with finerenone are directly addressing the question in cardiac failure, and you could see from those graphs presented that it does appear to have a signal in cardiac disease, but currently management of cardiac failure prioritizes spironolactone. If, however, you have somebody that doesn't have cardiac failure but has ongoing chronic kidney disease in the setting of diabetes with ongoing proteinuria, then it may well be a useful agent to make that switch. In terms of tolerability, finerenone is perhaps somewhat better tolerated with less breast tenderness, for example, and hyperkalemia isn't quite as significant of an issue, however, still does need to be monitored. So like most questions, my answer is it depends, which may not be that helpful. I also just wanted to quickly touch on the issue, I think, with the SGLT2 inhibitors and genital thrush. And I think this is just a really important one to flag, that it is relatively uncommon, but it's an awful complication when it does arise. So it is something that I always warn patients about, that if they get red or itchy down there, that they should stop the SGLT2 inhibitor. Sometimes you can re-challenge with success, but certainly the genital thrush can be really, really challenging. The other thing I think is really important to forewarn patients about starting SGLT2 inhibitors is the sick day management plan, given the really rare but potentially serious complication of euglycemic ketoacidosis. And of course, there are other medications that go on that sick day management plan anyway, that we're talking about, things like RAS inhibition and metformin. So it's a good chance just to ensure that people have a sick day management plan.
Great. Alif, do you want to jump in on
I'll jump in on the GLP-1 related questions. I guess the main things are, with the GLP-1, the currently available one, especially Ozempic, like we escalate the dose slowly. So I think it's really important to do that in clinical practice, and with tirzepatide, it's even, over a longer period of time to get to the full dose, and that helps with the GI side effects. However, these side effects will happen in some people regardless. So if a person's prone to constipation and things like that, I always talk about that because that's a typical side effect. With we can sometimes see diarrhea that people develop over time too. So it's also important just to, like in all the clinical trials, we would escalate, and then if they develop side effects, we taper back to a tolerated dose. So that's another way of doing that in clinical practice, so you don't have to go to the full dose if you can't tolerate the full dose, obviously. The other important thing is around if you've got known gallstones. So there is, risk with potentially cholecystitis that can happen with these drugs. That just, needs to be, if they develop abdominal pain in particular, rarely, there is potential of pancreatitis as well in the clinical trials, though they the results, didn't necessarily indicate it in the SELECT trial that there was an increased risk. However, in real world studies, it is there. So, and actually, I've got a really nice slide. I don't know if I've got time, but there's a really nice real world study I can show you. No time. Okay. Anyway, they compared tirzepatide and semaglutide over, a huge database, and they saw the gastrointestinal side effects that we talked about, and the efficacies dependent on the dose as well. So yeah.
Great. Well, look, as I said, there are lots of terrific questions, and I'm sorry we can't go through them all. I just got one last one, perhaps for you, Chiadi. What about the role of imaging in CKM? How did you?
No, that's a very good question, and I'll say something briefly about aspirin since that came up as well. I'll just say that the aspirin question is always a risk-benefit discussion. Most patients with CVD, we're going to see a more benefit than risk in terms of putting putting them on aspirin. And it's important to note that people with CKM syndrome are usually those who are classified as very high risk CVD because of the confluence of risk factors that go along with that. And in stage 3, where we have very high concern for risk, that we concern there as well. And then in terms of imaging, I will say that for subclinical atherosclerotic cardiovascular disease, we still support the general concept of using that as a tool to understand whether you're dealing with a patient if you have kind of a more intermediate risk kind of criteria, where seeing a higher coronary calcium would, for example, push you into an area where we think about a more high-risk primary prevention strategy. There's an interesting growing data that suggests that the more severe the degree of coronary calcification, then you may even consider more intensive therapy. So it's going to be an interesting question about how that plays into our practice guidelines going forward. But then in terms of subclinical heart failure, I think that piece is very, very interesting. It's a bit of an unknown, how we kind of identify that in the population. I suspect it's going to be a combination of most recent ADA guidelines suggest using biomarkers and comorbidities, including diabetes and age, to suggest where we're screening for subclinical biomarkers of heart failure and potentially following that up with echocardiographic imaging when severely elevated. But that one is a bit of an unknown.
Thank you. Well, I think we'll close there, and I'd like to thank our wonderful panel for really, I think, covering such a broad range of issues and so many exciting innovations in the field. But I think we're left with the one message: is look at the whole patient and use all the resources that you can possibly find, and that includes all sorts of other health professionals. It is Heart Week in Australia this week, so just a reminder of that, and engage in any activities and don't miss a beat. Use our risk calculator in your next heart health check. The next slide, the heart health checks are a systematic screening tool in practice, and it contains a whole lot of resources that can help you in integrating those into your practice. And they don't just address heart health, they address kidney and renal risk as well. The risk calculator that we've demonstrated is available at cvdcheck.org.au. And we're also partnering with primary health networks to bring locally relevant CVD education to priority regions. And the next one's going to be in the ACT if you're watching from there, or if you want to go there. And finally, the My Heart, My Life peer support networks of safe virtual space, which connects people with heart condition to others on a similar journey. And the community offers people with heart disease in their care as a place to feel comfortable, share their stories, seek validation, and normalize their experience. And we just know that how much they appreciate that. There will be an update on our national acute coronary syndrome guideline that's coming soon. It doesn't just address the emergency treatment, it addresses the prevention and the secondary, primary and secondary prevention. So it's been a wonderful discussion. I'm very grateful to you all for attending. There's a recording that'll be sent through in the next few weeks, and we'd encourage you to complete the evaluation survey, which will automatically populate when this webinar ends. And once again, a special thanks to our panel, not least of all Chiadi, for getting up so early in the morning, and he's had a whole work day to face when we can all go off and go to bed soon.